But this is important when you're going to choose a treatment for a patient at the bedside, something that should be kept in mind, that these trials were all done in all patients who had symptomatic myeloma with limited comorbidities and generally fit patient, as Anthony Palumbo would say. Right? They had to be a fit patient to go through the clinical trial. And the clinical studies were not done in predefined patient populations. So even though we talk about myeloma biology, that there is the hyperdiploid and the non-hyperdiploid myeloma, and hyperdiploidy has a better prognosis, etc. But when we come to the bedside, we don't stratify the patient by diploidy. We also talk about high-risk genetics that they have poor prognosis. But all the data is after doing the clinical trial, you look back retrospectively and you pull out who did poorly and you say they had such and such abnormality. But you never actually planned the trial forward in the newly diagnosed myeloma patient for high risk separately and low risk separately. And also, we are told from the biology we heard Fonseca earlier this morning that not only there is a difference among the patient, but even within a patient, there are multiple clones. So the patient could have translocation 414, then there could be a subclone with secondary genetic changes such as 414 with deletion 17p or 1q plus, and that subset may be the one which is rapidly progressing. And of course, undeniable progress has been made in survival because in the population statistics, you can see it is literally double. The survival has been double 5 years from 29% to 45%. But still, we are not curing multiple myeloma. So now I have to tell you how to choose induction therapy. Now this term induction therapy, etc. is getting modified. So I kind of put it in the diagram and tell you how it is going to be done. So we have what we call as first line of therapy. If the patient is not eligible for going through or is not going through hydrotherapy and stem cell transplant, he will be started on treatment, and quite often that will be prolonged. So you'll have to say up to this time it was kind of induction and later on it is continued, it's the maintenance, so on. So that will be an initial therapy / maintenance. Whereas those patients going through transplant, there is a clear phases. There is an induction where you give 4 or 5 cycles, and then go through high-dose melphalan and transplant and maintenance. So I will consider how to choose the right induction or initial therapy as a general statement. Now there was 2 major studies presented in the last ASH meeting, which I thought if I just summarize it, it will bring us very much up to date how to choose the drug. So here we go. First one is called the first trial presented. It was a plenary presentation by Professor Farcon. And this was a very large study. Over 1,500 patients participated. And the patient received continuous lenalidomide or 18 cycles of lenalidomide, and this was compared against melphalan, prednisone, thalidomide, which was the standard of care in Europe. So we wanted to compare where is lenalidomide and dexamethasone in patients ineligible for transplant. Then there was another study, Anthony Palumbo presented it. This is an EMN, European Myeloma Network study. In this one, everybody was on continuous therapy. There was maintenance included in it, so everybody was on continuous therapy. But they did have a fixed amount of induction therapy. So you have lenalidomide dexamethasone induction for 9 cycles, or MPR, melphalan prednisone lenalidomide for 9 cycles, or cyclophosphamide lenalidomide prednisone for 9 cycles, followed by maintenance therapy. So what did we learn from here? So I have put in all the data so you can see it in one slide instead of going up slide after slide. And we can see, first of all, we are talking about patients who are ineligible for transplant. But patients over age 75 is critical in your population because that will determine what your survival outcome will be. If you have people all under 75, your survival may look very good. If you have a lot more patients over 75, your survival may look quite dismal. So this looks approximately a third of the patients are over the age of 75. And the efficacy for lenalidomide and dexamethasone, whether it is given continuously or just as an induction therapy for 9, you could see that you can get complete response rate anywhere between 10 to 15%. And that's, here you can see melphalan, prednisone, lenalidomide. So all the lenalidomide regimen are there. If you use proteasome inhibitor, you do double the complete response rate, whereas the overall response rate more or less the same. And of course, you have more intensive regimen, you can try to push it up. And we'll come to that later on. So we will say that melphalan prednisone is no longer the standard of care, and that's clearly established. So melphalan prednisone plus novel agent is the next choice. But now you can say lenalidomide and dexamethasone as a continuous therapy could be an acceptable treatment option. So then what will you choose will depend upon which country you have, whether lenalidomide is approved upfront, whether the patient can afford that therapy. So you are given choices. And you could see the overall survival at 2 years is more or less the same, except for a more intensive regimen. So 80% of the patients are alive at 2 years. Well, you can say, well, this is not long enough follow-up, this may fall out, that may fall out. There were 2 studies which had long follow-ups. One was the MPV San Miguel, where after 3 years of median follow-up, they published on it. And in the plenary presentation for lenalidomide dexamethasone continuous on, they also had 37 months of median follow-up. So what did we find there? So this is first the Mateos VISTA trial, melphalan, prednisone, and Velcade. Median follow-up is 37 months. And the current one, which they presented in plenary for continuous lenalidomide, is also median follow-up of 37 months. And what you see here is you could see that this is lenalidomide dexamethasone continuous. I can't see any difference between MPV and lenalidomide dexamethasone continuous, except you will save peripheral neuropathy, painful neuropathy for patients, and fewer patients coming off of the drug. So there is, lower, better tolerance. So lenalidomide dexamethasone continuous therapy is coming out right on target in this particular trial. So that could be looked at for patients who are not eligible for high-dose therapy. So what have we learned about choosing therapy for patients undergoing, high-dose therapy? So here, VAD was the induction therapy. We didn't want alkylating agent. That's the way to collect stem cells. So this was all in the early 90s. So VAD was then compared repeatedly with the novel agent. Thalidomide, adriamycin, dexamethasone, cyclophosphamide, thalidomide, dexamethasone, bortezomib, dexamethasone. So that was compared. And in the induction phase, you would see consistently the overall response rate and very good partial remission is almost double that of VAD. So we were able to say, as Vincent Rajkumar would say, VAD is dead. So we all decided VAD was dead. So then we needed to say that the proteasome should be included in the induction phase. But then if you look at the lenalidomide and dexamethasone, you could use 4 cycles of lenalidomide dexamethasone, collect stem cell, go through transplantation. And then if you look at the survival, you are looking at 3-year survival of 80 to 90% across the board. So you haven't lost out just because you chose lenalidomide as an induction therapy either. But there is, we'll talk about what the bortezomib dexamethasone does with the higher complete response rate. So you are getting this, that it's almost that you could justify, depending on the patient's clinical situation, circumstance, where you are, cost effectiveness, you can choose any of that. Now, if you are a believer that you want to increase the dose intensity, you want complete response, because that's the first step towards cure. And the patients who have high complete response rate, they will have better progression-free and eventually overall survival. And now, like Fonseca was saying, we have to use multiple agents and more effective because the patients have multiple clones, so you want to eradicate it. Okay, you have the choice there. So lenalidomide dexamethasone, as I told you, gives you about 10 to 15% complete response rate. Bortezomib improves it to 20. But once you combine bortezomib and IMiD, you can double it up, you're almost reaching 40. And then you have the second generation, carfilzomib, and you are now up to 50%. And this is without transplantation. And if you did the transplantation, you can expect almost 2/3 of the patient could be put into complete response in younger patient population. And then previously we used to say transplant eligible patient, and we had all the novel agent induction, then the transplant ineligible patient, we have melphalan. Whereas if you carefully look here, I just showed melphalan-prednisone backbone or normal agent backbone because I told you lenalidomide dexamethasone continuous is completely acceptable even in the patients who are ineligible for transplant. So you are deciding that the novel agent would suffice for elderly and younger patient. You don't need to use melphalan-prednisone, but you can use melphalan-prednisone because with melphalan-prednisone and Velcade, you can also improve the complete response rate almost to 40%. And you saw the MPV, the overall survival. Now, if we flip it and say it, MPV was equivalent to lenalidomide and dexamethasone continuous therapy. So you can look at it either way and show that we have made progress in myeloma due to the availability of more drugs. Then the people are looking at how to improve the complete response rate without increasing toxicity. So these are the study which was done in Europe in elderly patient population or patients who are ineligible for transplantation. Sarah Brigham presented it in the last ASH meeting. So this is carfilzomib, cyclophosphamide, dexamethasone. Before I had carfilzomib, lenalidomide, dexamethasone. So 9 cycles, and then carfilzomib maintenance every other week, 2 doses until progression. And what do you see? You could see now you are almost able to, going from 14% complete response rate, you are almost half of the patients you can put them into complete remission, even in this transplant ineligible patient. And that is what we used to get after tandem transplantation in younger patients in the olden days in the 90s. Okay. So without transplant, in the transplant ineligible patient, you can get very high complete response rate, and that depth of complete response rate is finally pulling this off in terms of progression-free survival. So we have to take notice of that. I don't know about the overall survival, and that's where I look at that continuous lenalidomide dexamethasone. If somebody says survival is the benchmark, then lenalidomide dexamethasone. So the depth of response hasn't translated into the overall survival. So that should be kept in mind. Now, at what cost? The carfilzomib, cyclophosphamide, dexamethasone, very toxic therapy. Look at the discontinuation rate. Of course, you have peripheral neuropathy, which is unique to bortezomib and thalidomide, venous thromboembolism, unique to lenalidomide, and there is a discontinuation rate in all these large studies anywhere between 20 to 35. But look at this one, 14%. But of course, this is a smaller, earlier study, so everybody was being watched. That's the beauty of clinical trial, right? When you want to use it at the bedside and use it in all patients, it doesn't turn out exactly the same. So it is important. Evidence-based medicine is generated in a different, distinct population as opposed to going to the bedside. So, should we tailor therapy? Is there another way to choose? How would you choose? Sure, you could have genetic risk. Proteasome inhibitors improve, but do not overcome poor prognosis of high-risk genetics. Why? Because all this high risk was defined in patients who have been treated with Velcade, Revlimid, and dexamethasone. So you retrospectively pulled out high-risk groups. So how could it overcome it? It cannot. Then age with comorbidities, dose modification, and intensity modulation, and we will come to the contribution by Palumbo on that one. And for severe renal impairment, you choose bortezomib, thalidomide, cyclophosphamide, dexamethasone. So I'll just give a quick example for each one. Here, proteasome inhibitor in high-risk genetics, bortezomib improves outcome in deletion 17, HO1 65 trial. PAD is bortezomib, basically. Recently I saw a publication from Palumbo. He started calling it BAD in his slide. And so if you see the green one and the dotted line, you could see they have come very closer. Whereas on the VAD arm, where thalidomide was used, they are wide apart. So clearly, bortezomib improves the outcome of deletion 17p. Then this is the Avet-Lasso from IFM, where they treated a patient with bortezomib, dexamethasone, or VAD in the randomization, and pulled out patients who had 414, and all patients had 414, and clearly those who got bortezomib dex did much better than those who were randomized to VAD. So clearly, improvement in the survival outcome of patients receiving proteasome inhibitor. Then this is the new one, Anthony Palumbo presented in the last ASH meeting, how to treat the elderly patient, coming up with the frailty score, age, Charlson, etc. So in my clinic, as I'm getting older, my junior faculty have said, anybody over 80, they will be seen by me. So basically, all frail patients are mine. So you could see that you can come up with ways to say how it is. But it is important. So you cannot treat all patients the same way in a clinical trial, and you will find out the outcome is bad. We all know elderly, frail patient, unfit patient, you have to tailor the therapy. We learned it with the high-dose dexamethasone, Vincent Rajkumar, when he said, high-dose dexamethasone was dead. Then we learned in subsequent, trials which have come out. So this is important to keep in mind, that you got to choose the treatment according to the patient's frailty. Then in renal failure, Heinz Ludwig has published extensively on that one, and he would say that you can use bortezomib, adriamycin, cyclophosphamide, thalidomide, and of course my friend Bill Benzinger shows VCD, VTD can be given very effectively and it will improve. But what I put here is the HOANS 65 trial, where we were told bortezomib is superior to VAD followed by thalidomide, both in progression-free and overall survival. But when Sarnaval presented it in ASH, it was so dramatic. Those patients who had renal impairment greater than 2, this is a dramatic improvement in the progression. Those who got the VAD, and in the overall survival, those who got VAD as opposed to getting proteasome inhibitor. So rapid tumor size reduction in patients with renal impairment. So choice does matter, so you should choose wisely. So how to choose right initial therapy? We could say choice could be dictated by genetic risk, could be host characteristic, age, performance status, renal function, comorbidities. I give you examples of each of them. And of course, choice should always include a novel agent. And that's very important. And if you're aiming for high complete response rate, 3 drug combinations are coming out, especially the second generation imidaz proteasome inhibitor combination is coming out exceptionally good. And high-dose therapy should always be included. So what is the future? Where do we go from here? So incremental increase in complete response rate could be done by a usual way of adding one more agent. So I can throw up this one, carfilzomib, lenalidomide, dexamethasone, with elotuzumab, so we can have an incremental increase. Or we can also look for recent developments, reliable and biologically relevant, molecularly tolerated therapy. So we have shown that there is a response to vemurafenib in a patient reported. And then we are all excited about genome-neutral therapy. So the patient could have high-risk genetics, but by golly, who cares what is inside that nuclear sac? Target the cell surface and get rid of it with an intact sac. Don't even care what is inside the nuclear sac. So you could have a genome-neutral therapy. So I think the future is good, and I hope now you're all an expert in choosing the right therapy for your patients. If you have questions, I'll answer that.